Okay, Panya, would you start to just give people an idea about the housekeeping issues that we have today?
Yeah, sure. So can you please bring up the slides, or I should go on like without the slides? I can start and then you can bring the slides if it's possible. Okay.
Hello, Giuseppe.
Can you hear? Yeah.
Hello. Hi, hello.
Okay. Okay, so hello everyone. I am Pernian from the ISAM executive team. And before starting the webinar officially, I just want to mention some housekeeping notes. The first one is about the video recording. The whole webinar is going to be video recorded and shared with the ISAM members and all the attendees subsequent to the meeting. So if for any reason you don't want to be in the recorded video, you may want to keep your webcam off. And another thing is about the question and answer part. As you have all seen in the agenda, we have dedicated some time to the question and answer and group discussion. And so we kindly advise you to raise your hand before asking any questions or providing us with your comments. And we encourage you to actively engage in the group discussion and question and answer session. Another thing is about the microphones. Please keep your microphones muted during the presenters talk, because we're going to be too many people, and so it's going to be a disorganization about it. But we recommend you to keep your webcams on during the session if you want to. And the last thing to mention is about the chat space. You can see it down there in the platform. And you can use it in order to just ask your questions or provide us with your comments. And at the end of the webinar, we're going to take care of all the comments and questions one by one. And yep, that's it. And we have 3 meeting staffs here during this webinar. You can see them in the attendees list. And if you have any questions or you have any problems with the GoToMeeting platform, you can send us a direct message and we try to solve the problem.
Okay, it's great to have you all here, and we are delighted to kind of be able to put people together for the ISAM Neuroscience Interest Group. But before starting the meeting officially, you have the option in the chat space to type your questions. So whenever we have a speaker talking about a specific topic, if you have questions, please use the chat space and type down your questions. Then we will be able to see what are the things that people are asking about, or if you have any specific comment or suggestion, just add that to the chat space. That would give us an opportunity to be able to have a sense about what people are talking about, and then we can kind of keep on discussion about those topics. Okay, so formally, we are going to start the meeting with Alex. Alex, please go ahead, and we are going to kind of formally start the meeting with you, please.
Okay, thank you. If you put the next slides. Good morning, good evening, good night, good afternoon. Thank you very much for the 200 odd registrants. I think there's more than that, but it is amazing. We're going through unprecedented times, and in a way, we felt as part of the International Society of Addiction Medicine, we felt with colleagues from US, Iran, and others that we should have a series of webinars. This is the first of what is going to be, I suppose, right now, 3 webinar series. But as you know, you never know what's going to happen tomorrow or the next week. We are dealing with something where, you know, it's an ever-changing target, and in a way we felt like all of us, most of us here as clinicians, we are trying to cope with the situation as well as we could, but we're also trying to serve our patient population as well as is possible. So these are the, I've put here a slide of, for individuals who are not either ISAM members or perhaps do not even know what ISAM is. It's the International Society of Addiction Medicine. Our mission is global excellence in addiction medicine. We have around 10,000 members right now, affiliates or individual members. And our vision, as I said, is a strong and forward-looking society in addiction medicine that focuses on providing education support. These webinars are one of those types of support because we believe in the values of innovation, respect, excellence, collaboration, learning, diversity. I can guarantee you the next 2 hours would be worth its while. We're not necessarily going to answer most of the questions, but hopefully together we can move forward and provide a better service to our patient population. Thank you very much. So we move to Ali.
Okay. Thank you. Good time, everybody. I am Ali Farhadian, faculty member of Tehran University of Medical Science and Substance Abuse and Dependence Research Center at the University of Social Welfare and Rehabilitation Science. I would like to appreciate ISAM for holding this webinar, especially Hamed, Alex, and Ramin, and Marilyn. And I would also appreciate your attendance. The idea of the interference between COVID-19 and substance use disorder was come up about 2 weeks ago by a group of international multidisciplinary experts. This group believes that it is a special situation and deserves specific concerns and documented their concerns and their advice as a manuscript that my friend Ramin, the corresponding author, is following to publish it for more visibility. I really look forward to have your ideas, your comments, and please let me cut down the introduction and get into my important topics. Thank you.
Okay, good. Now let's move forward to the next slide. So just to give people an idea about what we are going to do today and the next days after today, we have started to discuss about having a ISAM policy and practice interest group. And this meeting is probably going to be one of the first kind of meetings for ISAM PPIG. We know that COVID-19 is a global problem and we need international solutions for that. And that's really great that right now we have ISAM to be able to organize this international initiative to have the collaboration between different people. What we are going to do for the next steps together is basically having representatives from different countries, different regions across the world, being able to have a checklist about potential concerns, policies, practices on substance use disorder and COVID-19, and being able to have regular updates from the representatives about this checklist, about what is really happening across the world. We hope to be able to put together some short communication and some letter to editors that could be published soon on the fast review track. And also we are right now putting together an ISAM COVID-19 repository that would have documents that are international or in the national level that are going to be helpful to deal with the COVID-19 among people with substance use disorder. So please send us whatever you think that would be helpful for people across the world that is happening in your country or in your international organization. So we are collecting them all together in a Dropbox folder, and we are sharing that Dropbox folder with all those who are basically attending. And it might be interesting for you that we are right now using the ISAM NIG email, which is related to the neuroscience interest group. So as I'm the co-chair of the neuroscience interest group, we realized that because we already have a infrastructure in the neuroscience interest group. Right now we are using that infrastructure to be able to help the policy group. So hopefully the policy group would have its own infrastructure soon to be able to basically manage this process as soon as we get together and make that specific working group together. So let's move forward to the next speaker. And the next speaker, Alex and Ali, do you have any other thing about kind of thing that we are going to do right now?
No. What about you, Alex?
Okay, good. So let's move forward with the next speaker, Dr. Craig Katz. Dr. Craig Katz, are you available right now?
Yeah. Yes. Can you hear me?
Yes.
Hello. Good morning. Good afternoon. Good evening. Shall I begin?
Yes, please.
Okay. Sorry. So yeah, thank you to Ali and to the organizers for inviting me. I'm a psychiatrist in New York City and have a background in disaster psychiatry. And I think I'm supposed to kind of just briefly give some context from the world of disaster psychiatry. So I'll do that very briefly. If I can get the next slide, please. So at this point in the game, right now, what we're really focusing on is something called psychological first aid. And really, when we think about the aftermath of a disaster, an ongoing disaster in some sense, which is what this is, it's a little hard to stage things. But early on in the first days to weeks, really, we're talking more about psychological first aid, which is really ministering to people's basic needs. I would say kind of being more, addressing more human needs than addiction or psychiatric related needs or medical needs first, physical needs. And that is what psychological first aid is about. It's really kind of focused on the bare essentials, including also information, which is right now probably one of the most important things for people's mental health and well-being, is having up-to-date, and I have to say, brief and digestible information about COVID-19 and what to do. So that is sort of where, as COVID-19 affects different communities in the short term, that's what we're talking about, psychological first aid. And that means attending to people's distress, whether or not it rises to the level of an addiction disorder or an outright psychiatric disorder. Next slide, please. And the next slide, it just talks about the idea that there will be some portion of people that will go on to have an outright psychiatric disorder or a recurrence of a psychiatric disorder, and certainly with substance use disorders. And it's typically the case that people don't necessarily develop new problems post-disaster, but are more likely probably to develop recurrences of old problems. But this slide just kind of shows out that there are identifiable populations that are going to have higher risk for having a psychiatric, as opposed to, let's say, a more general distress or even normal, so-called normal response to a disaster. And it has a lot to do with, how badly they're affected by COVID, for example, losing loved ones or economic impact, to having prior traumas, to, of course, as I said, having a prior psych history, and to what their life was like, how their life was going before this happened socioeconomically. And a very, very big one is the presence of social supports after, in the course of the event. Having social support, even while we are social distancing, is an enormous buffer for protecting people from going from needing psychological first aid to needing psychiatric care. Next slide, please. And this is an oft passed around slide about the psychological stages of disaster. And it goes out from days to, this says 1 to 3 years, but as many disasters reveal, whether it's 9/11 or the BAM earthquake or others, disasters impact can last a very, very long time. And this slide kind of describes the sort of the initial surge in energy to respond, and then the kind of the drop off in energy, and then the building back of a new normal. How much this will apply to something like COVID-19, where there's sort of a slow burn or sometimes an intense burn, and it's an extended event. we'll see. But this is something to kind of keep in mind, including for ourselves as we try to respond, and where our own motivations and energy is. Next slide, please. And just to really wrap up with a few quotes. One is this was something that I saw on the United States Agencies for International Development Office's office in Sri Lanka after the Southeast Asian tsunami, and I think it puts it well. It's a marathon, not a sprint, and it's kind of have to be prepared for the long haul, including preparing ourselves and our communities for dealing with long-term, obviously, impact, socioeconomic and especially psychological and spiritual impact, and pace ourselves like this were a marathon, or this may be an ultra marathon. And next and last slide. And I think this is a point that I make over and over again to people. We want to be a person first, a physician or a healthcare provider second, and a psychiatrist, mental health professional third, meaning that people have many very basic needs right now, as they're not just facing the threat or dealing with having the virus, but also the economic and the disruptive impact. They're going to have lots of medical needs, and that's why I think as mental health professionals we have to actually be up to keeping track of what the infectious diseases experts are saying and have that knowledge on our hand. And then lastly, we're psychiatrists. And dealing with probably the big three of long-term psychiatric sequelae, which is post-traumatic stress disorder, major depression, and alcohol and substance use disorders. And that is my brief talk. Thank you very much, and thank you for inviting me, and good luck with the rest of this talk.
Thank you very much, Craig. Thank you very much. It was really, really great. So for the time now, we are going to have basically 4 panels, and each panel would be 20 minutes. And I really like to kind of ask people in each panel to just get things done in that 20 minutes. So right now we have a panel with Brian, Marika, Ryan, Ramin about harm reduction. And the first speaker would be Brian. Brian, are you online?
Can you hear me?
Yes, really well.
Well, here's my coffee. It is, what time? 5:15 a.m. and it is an absolute pleasure to be up with you to discuss this important topic. And I think that having so many people be here is a testimony to the importance of this topic to them and basically to the world. So I've been asked to briefly speak about harm reduction. I live in Vancouver, where a number of harm reduction modalities, and we're at the cutting edge of this. I'd like, if my slide is up, I can't see modality that I'm using here. I'd like to make a few remarks about addiction care and some medical care. Are we okay? Great. So in terms of understanding what we're trying to do with addiction care here is in the harm reduction realm, more than the opiate substitution realm, is the needle and syringe programs that are the life city in our communities really need to continue. It'll be important to keep our care providers safe in the provision of these life-saving supplies. But as this population is socially isolated to begin with, there's a great concern that it will be having an epidemic of COVID that we won't necessarily recognize. So we're trying to get providers of needle and syringes to be aware of the possibility of COVID in the individuals, not only to protect themselves, but refer them for early diagnosis so that we can find sentinel cases and actually institute broader testing within the community to ensure that a microepidemic is not developed and spread more. The same applies to our supervised consumption. Staff are very important in this context, and COVID screening in the way as I've described for the needle and syringe programs must also be in place. We have some interesting programs here around the world where there is the availability of injectable opioids as a substitute for substitution, and a small number of individuals who are particularly unstable. This becomes very difficult to deliver as individuals have to present up to 3 times per day. And right now, the guidance we have in place is to attempt to switch these individuals to more conventional opioid substitution therapy and watch them very carefully. Here also, in the setting of an opioid pandemic, we have had the availability of daily dispensed or more than daily dispensed long-acting narcotics. And in many cases, individuals are having to present to the pharmacy 2 or 3 times a day, and the opioids occasionally available in capsules. The capsules are opened and the granules are sprinkled in various substances, juice, yogurt, and the like. And pharmacists have expressed to us that they feel that this amount of contact that they're having with patients is not appropriate in the era of COVID, and have asked that we not ask them to sprinkle this. Now, obviously, this makes the opioids more divertible, and in this overall context, we're being asked to allow individuals for whom it is appropriate to carry their opioids with them, in which case it could be diverted either to be injected or to have them exchanged, sold, bartered for other street opiates, including fentanyl and carfentanil. So in all of this context, the 2 principles that are being applied is the safety of the staff that is delivering the service, and a desire to maintain individuals engaged in care so that we do not have a population for which overdose events will occur more frequently and COVID will be spread within this population. The testing for COVID is not open right now, at least in our jurisdiction, to individuals who are not at risk of being hospitalized. But I think that in this population, we're going to have to reconsider this, as social distancing is not possible, and as COVID could lead to many, many cases of COVID and worsen the pandemic, not only in the affected inner city population, but in the general population. So we'll be watching for sentinel cases and have an aggressive epidemic investigation approach. Now, if cases are developed, the whole concept of isolation and social distancing is obviously much more difficult in the homeless and in the unstably housed, and trying to identify options to address this, such as temporary housing that would allow social distancing to be applied in an appropriate manner. And finally, we must not forget the medical needs of this population. 40% have psychiatric comorbidities. Many are on injectable antipsychotic medications that, if they're discontinued, will lead to great instability. There will continue to be ongoing street drug use. We need to be aware of abscesses and other conditions that would require acute medical intervention, and that as services is a little bit more rationed in our emergency rooms and in our other facilities. We must understand that often bacterial abscesses can have significant complications, including osteomyelitis, endocarditis, and others, and they have underlying. So these are all things that we're going to need to address in this context, and that's all I have to say for right now. Thank you.
Shall I understand that it's my turn?
Yes.
So my name is Marika Ferri. I work at the European Monitoring Center for Drugs and Drug Addiction. WHO informed that the new epicenter of the virus, the COVID, is Europe. And the European Center for Disease Prevention and Control, can you put the next slide, shows that the first 3 countries are Italy, Spain, Germany, and France for the number of cases. So the contribution of the European agency is considered really needed. We know also that the drug users, is the next slide, is one of the vulnerable group. Up to now, in our agency, we have we are keeping in contact with frontline professionals to collect concerns more than responses. Although any moment today we will publish a web page with some recommendations issued by various agencies, and the intention is to link to experiences in Europe. The next slide. So talking in terms of concerns up to now from frontline professionals, there are the problems related to the lockdown policies in terms of drug users searching, for example, for their substances, and homelessness, risks of overdose, infections among professionals, restriction to access to services, the need to increase take-home methadone, the problems of prisoners and therapeutic communities and together, and then trying to pass as much as possible counseling and other psychotherapy to online systems in order to reduce time in the ambulatories. At the MCDDA, what we have done is that mandatorily since the 16th of March, we are working remotely. Luckily, we were already ready to do such. We had already all the technology to work remotely. It was instituted by our director and Alexis Gusdil task force, also in connection with other external networks, including ISAM. And there will be, as I said, any time today, this web publication. So we are very available for collaboration and keeping in contact. Thank you.
Hi, everyone. Great to be connecting with such a great group of people. What's morning for me as we all try to get a handle on this. So in the interest of being brief, given the time pressures that we're under, I'd like to first refer people through to 3 resources, which I've also posted in the chat. First is a guidance document that we put together for people with active substance use, so as to inform how they can reduce harm. The second is a document by the guidance for people engaged in substance use treatment. And the third is a guidance document for clinicians and opioid treatment programs. So these were collectively put together through the Yale program in addiction medicine, which is where I'm based. And I'm going to kind of key in on some key recommendations coming out of the harm reduction guidance, so that guidance document for people who use substances. First, I think it's important that we collectively recognize that, you know, we're dealing with COVID-19, but also a syndemic, wherein it maps onto all of the other inequities experienced by people who use drugs, specifically a number that increase their vulnerability to incredible harm during this pandemic. And these two are further complicated by a range of structural inequities: homelessness, housing vulnerability, policing, etc. So as much as we collectively push to inform practice, inform harm reduction practices, etc., it's equally important for us to push for the need for urgently needed, necessary structural intervention amidst this pandemic to address these inequities, so to house people as appropriate, so they're not living in cramped conditions, etc. So I hope people are positioned to engage in that work, and I'm sure so many of you are. Keying in on some of the core recommendations out of our harm reduction guidance document, certainly first, we need to prepare people for disruptions to harm reduction programs and involuntary withdrawal. What we're recommending to folks who use drugs is that where possible, that they stack up on drugs and harm reduction supplies, certainly while recognizing this is complicated by poverty, criminalization, and what's already being experienced as disruptions to the illicit drug supply. It's important for people to have contact with multiple dealers to try to manage risk within the context of that, particularly in areas with volatile, toxic drug supplies, like much of North America. And the people have access to medications that they need, food and drinks to help with detox. Certainly, these are challenging for folks and may not be possible for all, given the broader inequities. Second, and this is a little bit complex given the pathways through which this can spread, and especially in settings with fentanyl adulteration, etc., recommending that people continue to avoid injecting alone, particularly if they're injecting drugs that may include fentanyl or come into contact with fentanyl. Some recommendations for people to manage that risk would be to stay at least 6 feet away from other people, cough or sneeze in the arm, avoid touching face, wash hands for 20 seconds with soap and water, and to practice social distancing where possible, but continue to avoid injecting alone. Second, to call someone or FaceTime them or connect with them as people are able to, and ask them to stay online so they can act in the event that someone has an overdose. Preferably someone nearby, given that emergency services are likely to be disrupted. You know, alongside that, and there's guidance circulating that I'd be happy to help connect people with. There are protocols for peer witnessing that can be adapted for the purposes of managing overdose risks during this. And I think it's worth noting that supervised consumption sites have already started to adapt to this by enforcing some degree of social distancing within the operation of the sites by cutting the number of people who can be in them at all times. So certainly there's some opportunities there that people could replicate those practices in other settings. Second, and this is especially important now, but I continue to recommend that people not share supplies, which includes everything from injecting equipment, but also pipes, vapes, straws, bongs, vape, cigarettes, even drinks. People need to wipe down packages with an alcohol-based cleaner or wipe where possible, wash their hands, etc. You know, we're facing down the reality that people are going to be injecting with sterilized, or may no longer have access to syringes. There's a series of recommendations that people can follow within these documents to assist with that. So certainly there are steps that people can take, and you know, we need to collectively be smart about disseminating information to people. This document, a couple of the documents already are available in English and Spanish. We're working to get French and Spanish translations out of the harm reduction guidance document that I'm talking about right now. And where possible, we'll see that these can be disseminated more broadly. Thank you.
Ramin, could you hear us?
Okay. Hello, everybody. Good time around the world. Regarding the harm reduction, regarding the COVID-19, it's obviously COVID-19 is attacking all of the sectors of the community, especially the health sector. And among the health sectors, we think that our final stakeholders, people who use substance and people who inject drugs, are at the higher risk and at the highest rate of the vulnerability. One of the concerns regarding the harm reduction settings, as Brian said, that is the safety of the service providers in harm reduction services. Usually, the service providers, outreach workers, are not professionally trained healthcare workers. Usually, they are only peer groups. They are in crowded areas such as shooting galleries, shelters. Their work area is not usual as the hospital or some health setting, some regular health settings. They provide services for marginalized and stigmatized group who may not do. Those people are not able or are willing to follow the healthy behaviors rules that are needed in such conditions. Another problem is that the employers usually are not typical healthcare providers. Usually, outreach workers are working for the NGOs. That these NGOs are not exactly this typical healthcare providers. They are not even the healthcare provider are not trained as the usual healthcare providers, and some of them are extra users, and they are under a stressful situation, make extra users at a higher risk of the relapse. Already we know that the burden and the frustration and turnover of the trained outreach workers are very high. In this situation, it could be a little higher, and then the harm reduction services are at the problems. Another problem is that the decreasing the coverage of harm reduction for final stakeholders, such as PWID, is another problem. We know that we do harm reduction mainly for HIV prevention but it depends on the coverage of the program. But if the coverage decreases, we have lots of the problems. Possible shift of the resource, donation, and supports to the COVID-19 services is one of the causes that could make the harm reduction services in the limitation of the resource. Phobia of outreach worker and refusing to provide services for or going to the crowded area, they may be should have concern regarding their health situation, and they may refuse to provide the services. Harder access to the people that already are hard to reach population in quarantine or restriction situations is another problem. And moreover, a stressful situation can increase risky behaviors among people who use drug and shift them to the higher risky behavior in which more harm reduction services are needed as a result. And finally, we have a higher gaps between the services and the needs of the stakeholders. This could be a really serious problem. We have to be prepared for it. Thank you.
Perfect timing. Perfect timing. That is fantastic. So let's move forward for the second panel on OST, and we have Ali, Alex, and Nico. And they have 20 minutes to cover the things related to OST. The first speaker would be Ali. Ali, please go ahead. Ali, could you hear us?
Yeah, sorry. Sorry, I was disconnected. Thank you. It's my turn?
Yes.
Okay. In this part, I was talking something about some consideration about opioid substitution treatment and coronavirus. There is a fact that any personal contact may be harmful for patients and virus transmissions. Then the goals are to restrict any personal contact and decrease patients coming to the clinic or to the pharmacy. For this, an OST program, a flexible OST program, should be taken into account in this situation. For example, in addition to other hygienic principles, delivery system should be trained to handle the process of tablet delivery with the minimum hand contacts. And in this phase, sprinkling is not recommended, as it may increase patients' amount of time at the pharmacy or the clinic. There is another important issue that for the newcomers, buprenorphine seems to be better in comparison to methadone, as it is safer and faster to dose escalation and giving take-home delivery. Next slide, please. Next, thank you. There are some considerations regarding different stages of maintenance treatment. The first stage is early stabilization. As you know, early stabilization phase has a higher risk of mortality and opioid and methadone toxicity. Then we do not recommend to be the protocol to be relaxed in this stage. However, the patients should avoid any unnecessary visits and rigors. For the next phase, late stabilization, the physician should be cautious about differentiation between some individual signs and symptoms like myalgia, sweating, nausea with signs and symptoms of virus infection. Sometimes the pupil size and the emergence of fever are good points to differentiation between these two syndromes. In maintenance phase, one of these important issues is the interference between medications like antiviral medications and some other medications with methadone level, that they may inhibit or induce enzymes for metabolism and may end up to toxicity or withdrawal. The physicians should be cautious about the methadone and may they want to adjust methadone level and go for the split doses. The last phase is termination. Termination is a stressful process and needs close supervision and constant consultation. It is not recommended in this situation of catastrophe. Then the physicians and treatment team should persuade, encourage their patients to postpone this phase to a better time after the catastrophe. Thank you very much.
Thank you, Ali. Okay, I thought I'll do my presentation around the questions that we've put forward to all speakers, and that includes items first considered as non-essential and what might be the unintended consequences for the substance using population, and examples of good practice. I'm going to concentrate around the provision of medication, and I'm going to list, from my own personal experience last week, and as we speak right now, I've just been told that half the pharmacies in the area I work in have been just closed, is the unintended consequences of certain actions being decided by other stakeholders, and how that would implicate the provision of what has been now, certainly in Scotland, has been officially deemed as an essential services. So the provision of medication and harm reduction and opioid substitution therapy has been officially considered as an essential service. So in some way or another, we need to continue providing that service. So the unintended consequences include the potential medication shortage. As yet, we do not have that because the transport systems are still working in the UK, but there might be some elements there where the 1 milligram per mil methadone, could and should be replaced by other types, generic or higher doses. Of course, using that on a case-by-case basis, and one needs to be prepared for that. Community pharmacy disruptions to dispensing and consumption on premises arrangement as well. And there's been an understanding that we would try as much as possible to delay, to prevent delays in community pharmacies of individuals having consumption on premises. But again, that carries some risks to some patient population, and we need to be cognizant of that. As important is the disruption of injecting equipment provision and the take-home naloxone program and delivery of that. We should not, in a way, so we're in a situation where we should not divide our priorities between harm reduction and treatment. This is, we're talking about the same patient population, so we need to be really effective in all elements of the provision of care for these individuals. And this might potentially be a problem in my area here, but it's worth noting that we have now already agreed to look at all deliverables in one go, rather than getting different services, providing different deliverables. Prison liberations is one of those issues that we, in our continuity plan, have not really looked at very closely, especially if there is a requirement to continue OST the same day after the person has been liberated from prison. And the other thing is, of course, we talk about substance misuse as drug misuse, but we should not forget that not only does this population have a polydrug, polysubstance, polymorbid condition, but also patients who present to our services with alcohol-related problems. And I think this is something that we need to be very cognizant of it. But on a good note, I'm sharing two good practices here. As I said initially, we're now an essential core services, which essentially differentiates us from the non-essential, but also from the critical services. But it also means that we have the backing of all the relevant stakeholders to deliver the service. But one thing which I think is a testament of what we're going through right now is that gone are the days of being voluntary or statutory, non-statutory, etc. Voluntary organization staff, as I speak right now, are delivering methadone and other pharmacologies to patients' homes, especially the population that are self-isolating, with a view of expecting this to increase. And that's really good thing to think about. We, of course, started by asking key workers and nursing staff and healthcare staff to help us with this. But I think inviting the volunteer organization from day one to release staff to help us with this seems to be working really well. Thank you very much. Nico.
Unmute. So, hello everybody. I'd like to share a little bit about some of the thinking here in Australia. I'm not sure if I have one slide or two. So, at the moment, we're all working full-time in preparation mode for the plans for the various different phases of this virus. But we've been looking mainly at spread from outside and to kind of a minimal local spread, which is, I think, is the phase that we would say that we're in here now, and to moving towards widespread local spread, and then finally to some kind of recovery phase, to look at the various different ways that different health services will have to respond, including opioid pharmacotherapy services, from the identification of cases and high-risk people who are coming to the services, to the protection of transmission of between staff and to the staff, to the protection of transmission to the client population, and then the provision of essential services, which includes opioid pharmacotherapy. So at each of those stages, we are looking at different how each different service would respond, and this is changing for many cases. The plans are evolving day by day, but certainly having those plans in place is kind of helping those services prepare for the arrival of the situation. So if we're talking about opiate pharmacotherapy, at the moment we're looking at detecting people who may have the virus as they come into the pharmacotherapy, and this is the recommendation here, is to do this through a combination of questions about recent travel and other high-risk events combined with symptoms of fever. We're also measuring temperature in our service to everybody who comes in. Once somebody is identified as high risk, they would then be tested either on-site or off-site with people wearing the appropriate equipment. And if somebody was identified as either having COVID or highly likely to be that, then they would have to receive the treatment in a way that protected the staff from transmission in that situation. So for methadone, this would likely mean that the person would then receive a higher dose of take-home doses. Maybe when those take-home doses were being given to that person, they would be delivered and not in a kind of hands-free method. Maybe if the person was in home isolation, you would take the methadone to their house, you would knock on the door, the person would come out, then you would put them down and take a photo demonstrating that you delivered them, or something like this. Initially, if kind of a treatment interaction was required, then the staff member would be wearing a full personal protective equipment, including an N95 mask. And this would be unavoidable if you had to administer the depot buprenorphine, for example. Of course, for everybody in all situations, we're encouraging hand washing and social distancing within the services. Many services have got kind of tape on the ground indicating where people should stand so that they're not standing too close together to increase the risk of transmission within those services. At the moment, we're not using the normal surgical masks for kind of intermediate levels of risk, although many people in the population are wearing them. The exact combination of interventions for each of these kind of placements on this grid varies between services depending on what service that they're delivering and our current thinking. It also changes on the instructions from the government. Also, depending on what resources are available, there are certainly less personal protective equipment and testing capacity in the country than we would like to have, and some of the recommendations also reflect that shortage at the moment. I'm not sure if there's another slide also on some of the recommendations specifically for opioid pharmacotherapy. So certainly some if somebody, for example, presented to the medically supervised injecting room, then they would be offered pharmacotherapy as an alternative to using that facility. And they're always offered that alternative, but this could be if they were identified as having the COVID virus or having a fever and symptoms, they would be offered that as an alternative. A large emphasis of our concern is of maintaining current services with less staff, and that, as has already been mentioned by some of the other speakers, this largely involves giving longer prescriptions and more take-home doses to patients. There's, in the treatment system in my state, many of the patients are cared for by sole practitioners who have a large number of methadone or buprenorphine patients, and we're looking at ways in which we can support those staff members if they become unwell. It's likely that there will have to be measures for emergency pharmacotherapy if those people are unable to fulfill their duties. But at the moment, we're working through those as we speak. Some of the other specific pharmacotherapy considerations have already been mentioned. Certainly the long-acting injectable buprenorphine is very useful on the one hand because it only has to be administered once a month. On the other hand, it does require physical contact, and which would require personal protective equipment. It's possible also to give single-dose detoxification regimens with buprenorphine, either with the depot buprenorphine or with sublingual formulation. And I think other aspects of the pharmacotherapy have already been mentioned by the other speakers. So I'll leave it there. Thank you.
Perfect. So we still have something like 3 minutes from this panel. If there is anybody with a specific experience regarding the OST, we'll be happy to hear those experiences on OST. Okay, let's move forward. We will have time in the next step to have comments from people on different areas. So for the next panel, we will have Rick Rawson, Mark Potenza, and Greg Bond, who are going to talk about abstinence and recovery-based intervention and psychosocial support. So the next speaker would be Rick Rawson. Rick, could you hear us?
Yes, I can hear you.
Good.
I want to make sure I'm very clear on the parameters of my discussion. I'm going to talk about the continuation of behavioral treatment for patients who are in treatment and who are not able to personally attend treatment because of social distancing principles, and that they are, so everything I'm going to talk about will be referring to virtual communication over internet or electronic communication, assuming that in most places, at least here in the United States, most areas now are on social distancing recommendations with very few exceptions. So, and this is, I'm working with a couple of groups giving them advice, but I have no real evidence that my recommendations are the best recommendations. Next slide. So obviously the major component of most behavioral treatments are in-person sessions, either individual or group, that provide patients with new skills and support, encouragement, and empathy. Given that current social distancing recommendations suggest these in-person contacts should be minimized, then I'm assuming that the services will need to move to a virtual platform. Methods to maintain individual and group sessions via virtual communication, there are currently many. Now, obviously, this whole presentation ignores those people who don't have resources for being online, and I apologize for that. But in the cases where people are able to access virtual platforms, there are a number of them, including Skype, Zoom, Facebook chat, and others. I don't know about the security or confidentiality on these platforms, but I do know they are ways of being able to hold individual sessions and group sessions with patients to discuss their addiction issues. There are other ways to communicate with patients on an individual basis using texting. Google Voice can provide a telephone number so the therapist doesn't have to use their personal number if that's a concern. WhatsApp and Twitter and other messaging services may be available. So I think the first framework is what, if you're going to do groups, which of the platforms you find you're most comfortable with and are most accessible. And then for individual communication, there's certainly telephone calling and telephone texting and the like. Next slide. Running a group virtually, just some sort of common sense perspectives. First off, from the position of do no harm, when these patients are calling in for their group session, one of the benefits, hoped for benefits, is to help them to reduce emotionality and become more stable, and to have a place where they can talk and get some reassurance, reduce their anxiety. So it seems important that before you start a group, the leader should briefly chat with each individual patient to ensure they're not intoxicated or they're not extremely emotional. Those who are intoxicated or extremely emotional should be communicated with in an individual session, over a virtual individual session as soon as possible. But having them in the group could be really damaging to everyone else in the group. So there should be some before sessions. There should be a quick screen that's done before people are, quote unquote, into the group. In the structuring of the group, I'd recommend 3 to 5 minutes for patients to do a brief overview of their current situation, where they receive feedback and empathy and support and encouraging style, a motivational interviewing style. The group leader is going to need to very assertively manage communication, with the primary communication being the therapist and each patient. Comments from other patients can be allowed per discretion of the group leader, but free-form, unmanaged communication will be counterproductive and chaotic. There are many sites where people can go for sort of general chats where they have interactive chats, but I think the structure of the group session will be very important. After a status update by each patient, a theme or a topic would be useful. Next slide. These are a list of some of the topics that I won't go into each one of them because of the time, but I do think it's for patients to develop some structure to their day to the extent possible, avoiding high-risk situations. Exercise, there's data that exercise can be useful. Helping them, trying to reorient them away from the idea that they're being restricted or, you know, involuntarily put in a timeout situation, but to use their time for positive activities and try to help them with some to counter the catastrophizing and anxiety. Also, some specific topics around emotional regulation, meditation, mindfulness, yoga, exercise, and the like. Next. There are some online addiction resources. I won't go into these. You can see the slide. There are the websites. There are online meetings, AA and Smart Recovery, and a whole variety of online technology-assisted treatment. And there's plenty of other websites that I didn't list. And finally, one more slide. And given that a priority of these sessions would be to help patients and encourage them to engage in positive behaviors and non-drug related behaviors. This is just a sample of a few of the apps that are available to help people develop other activities with their time so that they can use their time more productively. And I'll stop.
So thank you. I'll take the next step in this important series of presentations. So I'd like to thank ISAM for inviting me to participate. And I'll talk about some of our responses here in the US and particularly at Yale, at my home institution. This first slide shows an article that was published a few days ago in the Yale Medicine magazine that discusses some of the aspects of COVID-19 and the coronavirus situation and how this may impact addictive behaviors, including aspects of social distancing and stress. And this builds off of some of the prior presentations that, for example, Drs. Katz and others have described. So I won't go into details, but there is a link. Next slide, please. The next slide will discuss some of the aspects that Dr. McNeil covered in his talk, and I include links to some of the recommendations that the Program on Addiction Medicine, in conjunction with the Division of Substance Abuse and others, has been developing guidance measures for substance use disorders that he covered in greater detail. So next slide, please. And I would also discuss a rollout of a mobile app, and this is being done by Addiction Policy Forum in association with CHESS, the Comprehensive Health Enhancement Support System. And this Connections mobile app is empirically validated mobile app that's been tested over the past decade or so, with initial publications coming out over 5 years ago. Next slide, please. The app contains multiple features that It offers support for patients in recovery, pro-social engagement with others in recovery, connections to care providers, as well as digital cognitive behavioral therapy. And this builds off of also Dr. Rawson's presentation, as the CBT in this package is built off of and includes CBT for CBT elements that Kathy Carroll and others have tested. The app was launched on Thursday. The free access to the app was launched on Thursday, and over 900 people signed up in the first 24 hours of operation. Next slide, please. This schematic, and these next schematics are showing are from the Addiction Policy Forum that shows some of the features of the app and what the app may look like on people's smartphones. There are aspects such as daily check-ins, recovery through support, discussion groups, and messaging, as well as care plan reminders, medications and appointments, and other features. Next slide, please. Some of the features include threshold questions during a weekly brief addiction monitoring survey, although more frequent contact is permitted and encouraged and incorporated into the package. There are both protective and risk factor questions, as well as motivational messages upon completion of the weekly brief addiction monitor survey. Next slide, please. Then there is also the feedback that is provided on a provider dashboard. Next slide, please. And this technology, as I mentioned, is an evidence-based platform that was developed by David Gustafson and colleagues at the University of Washington with support from NIDA and IAAA and NIATX. Next slide, please. And these are links to some of the description of the app and the platform. And I should mention in full disclosure that I'm on the advisory board for Addiction Policy Forum, so I've been involved in some communications, and the Addiction Policy Forum is a nonprofit organization that is aiming to help people with addictions. And that is the list of the slides. So thank you for your time and attention.
Thank you, Mark. Thank you. Okay, let's go for this one. I'm not sure if Dr. Greg Bond is online right now. Greg, are you online? Okay, let's move forward with the next panel, which is about.
Ahmed.
Yes.
Can we just say, you know, in that slide, you know, there were some really good resources from SAMHSA, and they would be, you know, worth putting them in the repository.
Yes.
Thank you.
Okay, and now we are going to have presenters from different parts of the world describing what they are doing in their own kind of states or in their own countries. And the first speaker would be Dr. Jason Beeman from US, from the state of Oklahoma. Jason, are you available?
Yeah, I'm here. Can everybody hear me okay?
Perfect.
So I'm Jason Beeman. I'm the chair of psychiatry at Oklahoma State University. I'm also the medical director at the largest inpatient treatment center in Oklahoma. I think as far as the burden of the virus, Oklahoma would be very similar to most of the places you guys are at. We are far behind the experiences of Italy and Iran and a lot of Europe. We have absolutely no testing. If I were to order a test right now, it would probably be weeks away. We have some hope that that will be dramatically improved over the next 5 days. But for right now, we just have zero ability to get testing on anybody in the state of Oklahoma. We also have no PPE. And specifically in the treatment center that I'm at, we've got nothing more than a handful of surgical masks. So I don't believe we have any ability to care for somebody that was quarantined or suspected of having the virus. And that is very concerning for us, that, our obligation, I think, is first to our clients that we have in the building, followed second by clients that are suffering from addiction that need to come into the center. But we don't want to risk the lives of everybody that's already there. It's about 150 people. We are in an old hotel, cinder block, but very, very close proximity to each other, very little ability to socially isolate. At our center, we do have mostly indigent, and most of these individuals can't just be discharged because they don't have stable housing. So we are really, really trying to protect the people that are in the building. One of the first things we did is about 2 weeks ago, we stopped detox admissions to our detox unit because we don't feel comfortable with the ability to screen, not knowing, I think yesterday we had 67 confirmed cases in Oklahoma. We're being told by the State Medical Association that we should really expect that to be 10 or 11 times higher. And so we don't know what's out there, and we don't feel comfortable taking people with detox symptoms like fever and shortness of breath, URI type symptoms, that we can adequately screen them for having the virus. So we did stop that. We have also implemented very aggressive infection control. Nobody is allowed in the patient care area unless you are taking care of patients. All administrators have been blocked off. Most people at the facility are being encouraged to work from home unless they're involved in patient care. We're telling everybody not to touch anything. We're actually engaging the clients and being part of the solution. And after at so many predefined intervals, we're asking them to wipe down equipment, coffee pots, and the handles to the ice and water machines. We've suspended all groups. Starting today, we will hopefully be doing 100% virtual sessions. We've suspended the cafeteria. All meals will be in patient rooms. And really, we're just trying to provide as much treatment as we can while keeping everybody safe. We are starting to have the conversation of what would it look like if we had a case. And honestly, I don't know what else we could do but close the facility, because I think it would just spread like a wildfire. And at the end of the day, our first goal is to keep people alive. And so, but we don't want to close the facility unless we absolutely have to. The largest facility in Oklahoma by a lot. And just because our operating costs are always so narrow on being profitable in the first place, that if the facility closes, it may not reopen. And I imagine that's the same type of situation that most facilities around the country and probably around the world are facing. So very, very, very dire circumstances. We're trying everything that we can.
Thank you very much, Jason. I just want to get sure that Giuseppe from Italy would be able to share his experience. I know that because Giuseppe is right now involved in the kind of first line of responders to the problem, and I know that he needs to go kind of on and off to the meeting. So right now, Giuseppe, I just wanted to get sure that you are able to kind of listen to the other experiences, or you just want to jump in right now and share whatever you are going to talk about Italy. Could you wait for the next 10 minutes, or do you want to start right now?
I hope so. So please go ahead, so I can also rest a bit.
Okay, good. That is good, because we have been thinking that it might be a better idea to have Italy at the end, because I mean you are more experienced, so we are going to have people who are a little bit kind of behind in terms of what is happening in Italy, and then we have your experience and the experiences in Iran, which are the countries that are ahead of us in terms of what is happening in that crisis. Okay, the next speaker would be Susanna Galia Singer from New Zealand. Susanna.
Hi, Hamid. Can everyone hear me?
Yes.
Yeah. Okay, so in New Zealand, today we had the Prime Minister tell us that we've increased the alert system from level 2, which is reduce the impact of COVID, to level 3, and within the next 48 hours, we're going up to level 4, which is quite a quick change in terms of how we provide the services, both within substance misuse, psychiatry, and the rest of the services. So what the Prime Minister has said today is that we need to be acting early, decisively, and go hard on it. So at the moment, we've only got 102 cases of COVID. So compared to other countries, it's not too bad a number. However, there is evidence as of today that we've got local transmission just started, which is why the alert level has increased. So from non-face-to-face primary care consultations and, you know, considering non-essential elective interventions, we're now having to consider what to do with our outpatient care, which is the majority of care that we provide for substance misusers is outpatient type of care. And what do we do with this? Is this considered as essential care for substance misuse services? Can we provide it in a different way? So at the moment, this is a question that we're asking ourselves. Are we able to provide virtual clinics, virtual groups, telehealth? Does our system support video conferencing? So for example, we've got the Substance Abuse Compulsory Assessment and Treatment Act in New Zealand. But how do you put somebody under the Act, if they need to be under the Act, without putting healthcare workers at risk? So we're making sure that legally we do have video conferencing to be able to review people through video conferencing and be able to put them under compulsory treatment if need be. We're also considering other factors, environmental factors like waiting rooms, making sure that the waiting room has only one person in it, for example, and other people will have to wait in the car before they come in. Just simple measures as that make a difference. And then considering really prioritizing what is essential care, who requires essential care. And some of the groups we're thinking about are those with comorbid cognitive impairment. Is inpatient detoxification necessary? If it's necessary, who are those people who need to have it as an inpatient as opposed to home detox? And how essential is it to physically review those people on opioid substitution treatment? Could you do it through a video conferencing approach?
Okay, Alex.
It's designed by our customers. We're fumbling about looking for buttons to navigate the meeting.
Okay, thank you, Sue, for that. I'm fully aware it is 2 o'clock in the morning there. So I'm giving a presentation on behalf of Norbert Scherbaum from Essen, who is medical director and clinical lead in addiction services and mental health. And about an hour ago, he sends his apologies because he's been called to an emergency meeting, but he sent us this slide and more reflection with a view of doing more detailed presentation in subsequent webinars. So in Germany, we have a problematic development of the rehab clinics, which they're now shutting down with unclear recompensation, and this seems to be an issue not just in Germany but other places. Regarding MMT, the relatively strict rules are officially weakened, and we've heard this from other countries and during the other panels, in order to keep running maintenance treatment. And when it comes to patient detoxification, it is still available but limited. Therapeutic chain does not function now due to the shutdown of rehabilitation clinics. So I thought I'll present this for now with a view of subsequent webinars. We have more details from Norbert himself. Similarly, we've asked Christos Koumstidis, who's the drug coordinator from Greece, but works as a clinician, as a consultant in London and in the field of addiction and mental health. And this is the message that was sent to us about an hour ago as well. So the major changes of Greece, continuation of provision of services, no different from other countries, protection of opioid substitution treatment dispensing units. In Greece, OST is provided from units based at local general hospitals across the country. As the need for space to provide treatment for COVID increases, general hospitals are instructed to find such spaces. And I'm sure this is a reflection of other countries as well. A compromise solution has been agreed with a plan to reduce number of units where possible, which unfortunately will increase traveling and risk for clients. There's also delay in treatment entries, as all types of treatment facilities are starting to have long waiting lists. So treatment facilities already have long waiting lists, and this episode is making things worse. The biggest challenge is the management support to homeless people in the center of Athens. A good percentage of those are intravenous drug users and migrants. Street work has now stopped and needle distribution is only taking place at certain spots. And I think this is a very relevant point. You know, we talked about the homeless and the residents, but what about the migrants, which of course in Europe is quite a substantial problem, but also in other areas of where there is conflicts, long-term conflicts going on, such as the Middle East. During such a crisis, our vulnerable population could be further stigmatized and left without support. But I'm sure Christos will come back in subsequent webinars. Thank you. So it's Fatima.
Fatima, could you hear us? We had Fatima in the first of the meeting, so.
Sorry, can you hear me?
Yes.
Yeah. Hi. I will give a brief presentation of the pandemic plan in our Department of Addiction Medicine in Bergen, Norway. The contingency plan determines all the profound changes in our service delivery system. We have undergone profound changes in our system. It is about allocation of the resources and capacity, changes in our routines and procedures, and at least providing up-to-date information to the staff and also to the patients all the time, and continuously training needs of the staff as needed, as well as equipment needs and supply and facilitate testing of the patients and also staff if needed. So we have facilitated to do that. The plan underlines some general rules for outpatient care, emphasizing indirect patient consultations using telephone callings mainly and Skype meetings rather than direct consultations. The elective inpatient admission is reduced. However, we have established a new specialized bed unit to favor the patients who are infected or coming to be infected in the coming days and weeks. We will ensure those close cooperation with municipal services to take care of the more vulnerable patients, like those who are homeless, before discharge from our services. And all the time, we will follow the up-to-date national advices and governance. For example, the Norwegian Center for Addiction Research has recently released information to health staff and also drug users, providing advices on, for example, being aware of lower access to illicit drugs, advice to divide the dose and take less amounts than usual, to save the drugs and to avoid a withdrawal, which we will be faced with in the coming days also, we suppose. So we are going to make some routines and procedures for the treatment of patients who will ask help about that. Avoid the most dangerous ways to use drugs is one of the advices. Avoid taking drugs while alone, and get a naloxone nasal spray as overdose prevention, and also keep a lower threshold to contact health services, particularly for the more vulnerable groups. And the main goals with this approach are to reduce the risk of infection among the patients and the staff, and provide continuously information to the patients how they can help themselves. We have made some simple posters for the patients with the instructions and with the informations. We aim to still provide proper medical and psychosocial treatment for the patients as well, and reduce the risk of dropout from the treatment, particularly substitution treatment by methadone and buprenorphine, to reduce the risk of overdose in this high-risk group. And we will ensure outreach services and the home delivery of the medications to the patients, mainly by health staff, rather than meeting them in our outpatient clinics. And also consider more take-home doses based on individual assessments and risk of overdosing. We encourage also the patients transfer from sublingual formulations to depot buprenorphine to reduce the needs for physical contacts, for example. We also aim to reduce the risk of overdose and overdose deaths by reaching the more high-risk groups, elderly, those with multi-morbidity and malnutrition and lower living standards. And we especially aim to provide care and support to patients who may experience increased anxiety and social isolation. We use frequently phone consultations, which with good results and response from the patients. And finally, we will enhance the low threshold capacity for intake and uptake to the treatment, especially opioid substitution treatment. Thank you for your attention.
Okay, now Gulare from Iran. Gulare, could you hear us?
Yes. Can you hear me?
Yes. Bold
Okay.
and loud and great.
Okay, perfect. So as you may know, Iran is among one of the countries that is dealing hardly with the situation of COVID. One of the at-risk populations who has been that well, the needs of whom are not that well met are the people who are living on the streets and people who are using on the streets. I don't know and how far you are informed, but Iran has one of the highest rates of opiate use worldwide. Also, we have a very high number of people who are using directly at the streets, many drug use hotspots, shooting galleries, as Ramin Radfar was saying, as also Ali Farhoudian was mentioning. We have over 1 million people who are using methadone in the community, and there are over 55,000 people who are using methadone are on OSC, on methadone maintenance therapy in prisons. So what we have now, the situation we are confronted, and where UNODC Iran wanted to intervene was that we thought that we need to do something for the underserved populations living on the streets, and we are starting with the city of Tehran. What we did was that we developed a brochure, and we also developed 3 short podcasts. And we did a WhatsApp group, and we started some coordination for doing better outreach. I would like to explain this a little bit more. The brochure is only for people who would like to have additional information. But the mainstay of the prevention messaging and education would be the outreach staff who are going to either play the podcast because they have masks and they cannot talk and speak comfortably. So they will play the podcast with speakers. Speakers are procured for the teams so that people can hear, and if people want additional information, they would go to the outreach team and they could request for the brochure. This would be announced there. Also, hygienic hand washing would be taught as you do it usually, as you see it usually in the airplanes, where stewardesses show you how to use the mask, oxygen mask, and things like that. So the podcast would be talking. I'm all saying this in would be because our first trial is going to take place exactly now. People are going to the hotspots, and the results I can share later on. So I think that they should actually get started in a couple of minutes. They are going now to the city center of Tehran. So some additional problem in the brochure. I'm sorry for being disorganized. In the brochure, we have highlighted the importance of washing hands, the importance of not sharing supplies like pipes and whatever, cigarettes and things like that, to be vigilant of 3 symptoms of COVID-19, dyspnea, fever, and coughs, especially dyspnea. The other thing that we have also given telephone numbers, and the outreach staff would be there for referring people. Now, the problems we have are that in many hotspots on the street, there's no access to water. So the hand washing is not that easy. This problem is going to be solved. There are some lobbying and negotiations ongoing with the municipality. Maybe there would be the possibility to bring over some tankers with waters to some of these shelters. A shortage of supplies, I think that wouldn't be surprising for nobody because we just heard from Dr. Beeman in the United States that they have a shortage of masks and everything. And what do you expect from Iran and for the people in the outreach who don't have that many masks? But this is done, the NGOs are themselves, they are procuring, and UNODC doesn't have money for that. So this is actually, they're raising funds from the general public to get that paid, and also they're mobilizing other resources. The other thing is that the staff who is going, the outreach staff, they're usually, as Ramin was mentioning correctly, they're usually recovered users themselves, and many of them don't know how to do prevention. So what we are very much keen on is to do proper training over either in person or over social media, so that One, first, people don't get infected themselves, the outreach workers, and what is even, and they don't infect their families and other people. And what could be a disaster would be that if our outreach staff is undergowned and under masks, and if they are not looking after good prevention modalities, they could spread the COVID from one hotspot to the other, and that would be the absolute disaster. It would be better not to do anything if that would happen. So that is something we're very vigilant on, and it's also very difficult for people who are homeless to go and to have a social isolation. It's not only difficult in the hospital to socially isolate people. If you don't have a home and you don't have a roof, how do you want to socially isolate yourself? And also the general medical services for people who are using drugs are not that well available generally, and under these circumstances even less. So it seems that our next steps should be that we should focus more on the supplies, and also care for having, if possible, masks for our people in the hotspots, and also having the test kits. Maybe that would be possible. We are hearing from one of the NGOs that are trying to procure some test kits. And also these outreach teams, none of them yet has fever measuring devices, instruments, and they are also going to procure that. So we will be keeping on that and watching and see how things go. And I hope I think in a couple of hours, I will know how the first outreach session works out, and maybe I can inform later on better. So I think I'll stop here, and thank you for your attention.
Thank you, Galar. It was really inspiring. It's really inspiring to see how people in Iran, even with these sanctions, are doing a really great job for recovery community and substance use community in different parts of the country. Okay, the last speaker, the last basically formal speaker would be Giuseppe Cara. Giuseppe, are you available to share your experience in Italy?
Yes, of course. Hello, everybody, and thanks for asking to briefly describe the current situation here in Italy, or I'd better say here in Lombardy, because as you possibly know, we have in this country a very different situation across the country in terms of outbreak, and we actually live in the first original area where the outbreak took place. So what can I say? You all could read the newspapers, so we are experiencing a very difficult situation, but luckily this is different in different areas of the country. Possibly in a few months we will understand why we are experiencing such a difficult situation, because someone is calling me, but I'll call him back later. Because we had an extremely quick outbreak in the last 3 weeks with the progressive, possibly 2 prudential lockdowns, and we ended up in a complete lockdown 2 days ago. So basically, we're experiencing a huge shortage of staff and beds, and almost any bed in our hospitals has been reconverted to COVID-19 beds with different intensity of care. But for example, in the hospital where I work, we have almost 600 beds, and we have currently 550 for people with COVID. And we are experiencing also an extreme issue in terms of shortage of health staff, because most of our health staff are positive or sick and have been quarantined. and health staff has been redeployed in different settings. Also, addiction staff has been redeployed in A&D departments. We are experiencing some disruption in dispensing substitution treatment of both metal and naloxone, basically because of a shortage of health staff. And we are trying to cope with this situation, increasing the proportion of clients with take-home medications, methadone, basically, with some weekly provision, which we are aware might be dangerous, but currently we have no alternative. Again, in terms of special settings, we experienced, and this can be quite interesting also internationally, we experienced the prison riots 2 weeks ago, and people died by deliberate methadone or buprenorphine or whatever it was overdoses, and this could be taken into account for different countries. Another interesting anecdotal experience is about drug dealers, because basically the market is stuck and people don't know where to take the usual drugs, and it's highly likely that they will find alternative and not safe sources. And the only positive comment is about that at the end of the day, regional government made legal and officially recognized phone and web delivered interventions. So most of our social workers and psychologists are working remotely, very intensively, and this has been acknowledged also in terms of payment, which is something even in these difficult times we need to take in mind. And what else? I really, okay, we are experiencing a shortage of health staff, but luckily we just 2 days ago we got colleagues from China, from Russia, and mainly from Cuba, which is an interesting thing in terms of solidarity within the Western world, which is something I'm a bit surprised about, but we'll have time in the near future to think about. And that's it. I really hope that recent news about decreasing in deaths and new cases, which are slowly, very slowly decreasing, will mean that lockdown measures are working. And yes, I hope that no of your countries will have experienced a similar situation, because I believe we have quite a good NHS, but I'm afraid there is no NHS across the world that can cope with such a huge outbreak. So the only thing to do is to strictly apply social distanciation measures. That's the only thing that can work at this point in time. And I'm really sorry about the very quick and possibly pretty emotional report, but that's how things go. Any questions?
Thank you, Giuseppe. Now we have around 15 minutes time, and Alex is going to basically manage the question and answer panel of this webinar. So we have 15 minutes time. For those who are interested to ask a question, you can use the chat space and type your questions, And meanwhile, you can also turn on your mic and camera and also ask the questions online. Alex.
Yeah, thank you, Hamad. I think we had quite an unprecedented amount of good information, wise from people who are going through and people who are preparing such measures. And I think this is the time, really, in a way. I was checking. We have on average about 140 participants involved in today's webinar. I'm pretty sure there are some questions, some comments, observations. And Marika, you have a question. You need to put your microphone on.
Exactly. Yes, the question is for Craig. He showed a very nice curve showing that immediately after a disaster, there is a peak of internal solidarity, followed by some disillusion and then a worst scenario. I was wondering whether it's something that is going to happen. You may have seen example in Italy that people is now singing the national hymn and clapping hands to medical doctors. So I'm not living in Italy, but I understood that we are at the peak of the solidarity. So what's next?
Craig? I'm just wondering, one of Craig's PowerPoint presentation was that this is an ultra marathon. I think he initially said a marathon and then he said an ultra marathon. So people who actually do marathons can associate themselves with all those feelings. I don't know if Craig is with us or not.
He's not.
No,
right.
No, he's not. He's not, but I think this is an important situation, you know. For example, in the UK last week was the preparatory stage for us, and it's quite interesting, you know, everyone was enthusiastic and motivated. Today, this morning, you know, it's a lot of people have realized the seriousness of the situation. We still do not have a lockdown, but the fact that we are dealing and doing things in a different way, such as having meetings, even though within the same corridor online, is quite daunting. So I wonder, where the resilience is and how we can capture that resilience to prevent, you know, this disillusionment within the population, but also within our service providers and systems. Any comments for, you know, around Marika's observation from other participants? Are you all disillusioned?
No, Brian Conway here in Vancouver. The emotion was as important as the facts in terms of the last few presentations. And I would, anything that we can do to help the situation in any of the places. I mean, I don't know you very well, Dr. Beeman, but the emotion overwhelmed the facts that you were trying to share with us about the situation in Oklahoma, even at this very early West Coast. So I think those of us that are involved in this will need to draw on each other to make good decisions to help very, very vulnerable populations as we go forward. I think you know, that's where I'm seeing it right now.
So from Denmark, if you can, yeah.
Yes,
okay.
please.
Okay.
Yes.
So I have spoken with a number of patients or clients by the phone this week that was, and some of them are taking less drugs and coping and saying that saves them money. Some others are actually going into like benzodiazepine withdrawal because they cannot get their extra benzodiazepines. And I've actually had to resort to by phone prescribe extra, not because it's good, but because the Danish health authorities have said that in this crisis you can prescribe benzodiazepines over the phone, which you normally cannot. But I've had to do it because otherwise this person would go to cramps due to benzodiazepine withdrawal.
Yeah. Yeah, are other countries, other individuals experiencing that? We're at the UK, we're in a very bizarre situation where we have supplies of medication, and guess why? Because we were preparing for Brexit. And as a result of that, we do not have that problem. But I'm sure other individuals might, you know, agree or disagree with our colleague from Denmark.
Well, let's remind ourselves, Brian Conway here again, that benzodiazepine withdrawal can lead to fatal consequences. So I think that's, you know.
Absolutely.
Yeah, you have to prescribe anyway. So yes.
Yes. Yeah, and I suppose this is where, you know, we come back to the distinction between harm reduction, harm minimization, treatment, stabilization really is irrelevant. At the end of the day, is that we need to make some decisions, perhaps uncomfortable decisions, but you know, we need to do that for some of our patients. I think we had individuals from Israel.
Yeah, hi
Shall
there. Yeah, hi there. First of all, I want to thank everyone. You know, we're all dealing with similar issues. We've transferred all our addiction treatment programs to online programs. Here we have similar problems like everyone else. I just have a request. This has been extremely helpful for me. And it would be great if ISAM on the website or somewhere else, there would be a place where we can organize different resources, just like someone published the Yale School of Medicine resources, and even things like applications that people can use, download, etc. I think that would be extremely helpful.
Yes, and in the beginning we did intimate, and we would repeat this again, is that one of our functions for these webinars is to create a repository of resources for participants and their communities to use, you know, for free, but also, you know, and in a way, I think through Dropbox, we'll be able to do that. Yes, thank you, Michelle. Thank you. Tepesed, who essentially has left, he's feeling quite positive after a month or two of really difficult times in Lombardy and other parts of Italy, but also the presentations we had in Iran. And in a sense, even though it looks and feels dire for most of us, there's always hope. There's always something that, you know, we were always surprised about, but hey ho, you know, you get the best of humanity here dealing with difficult situations. I'm going to Hamid, I'm conscious of time. I'm going to stop there for now. I'm conscious that the second webinar might have more time for questions and answers, and participants will have.
It seems
Yes.
that we have a few other questions. Moses, do you have
any sorry.
urgent question that you want to share?
Yes. We're having occasionally issues with confidentiality in this, you know, COVID area, with sometimes having to divulge information. Usually we would not, even to agencies and people outside the agency where we are working with our patients. I wonder if you have come across this situation where you seem to be, I seem sometimes to be pushed to give information that in other times I would definitely not divulge information about patients I'm caring for. I don't know if this situation.
Any response to Moses? Moses comes from Malta. Any response from the participants?
Example, this morning I had a patient who is in quarantine. It's a mandatory quarantine. He was asking us to deliver methadone because he's got no one to come and pick it up for him. And some colleagues of mine were very insistent that we should not do this work and we should get third parties in to deliver the medication. I felt a bit uncomfortable about getting people who, you know, we would have to tell them that this person has a drug problem, he is on methadone treatment, but I sort of was pushed into making this decision because otherwise the patient would have remained probably without methadone unless someone of us was ready to go over and sort of be exposed to the infection.
In Denmark,
I can't. Yeah, Denmark.
yeah, we try to deliver the drugs home to people, and if they say they have symptoms, then the drugs is placed on the doorstep. You ring the doorbell, then you step back, but then you see the person taking the drugs from on the doorstep and closing the door. That's what we can do. We have no protective equipment, but we still try to deliver the medication.
I would surely prefer that rather than getting people who are not usually informed about these situations, getting them in. Yeah, thank you.
Moses, in the UK, there's been very clear indications of when you are able to breach the confidentiality through the information governance structures. And like any other, appropriate response, it needs to be proportionate and appropriate. And you deal with that on a case-by-case basis. I find it really disheartening that people are thinking of making money out of this and, argue the case that people would need to be paid in order to deliver a service when actually they're already being employed to do similar things. Hamid, are there other questions?
We have a few minutes left. We already have Geert Dam from Belgium. Geert, are you going to share your experiences in Belgium with us for just two minutes?
Hi everybody. Hi Hamid. Thanks for organizing. Yeah, I'm very late in this meeting because I had a long discussion with members of the government on how to approach COVID-19 in psychiatry. So I'm also much involved in the psychiatry and the implications in psychiatrical hospitals. So I do not think at the moment in Belgium, I see for the addiction care not too many problems at this point, unless that everything's changing to virtual tele contacts or telephone contacts, but opioid substitution medication, etc., is, as I have the impression right now, okay delivered. But we are really struggling at this point within large facilities as mine, where we have a campus with 190 beds of addicted patients that are inpatient, residential, and a lot of them on the mandated treatment. So we are in the process of creating quarantine units for these patients. And this gives a lot of difficulties, not only of holding them there, if possible, but also we have a big lack of materials and testing materials at this point. So we're struggling with most of it at this point with enough protective materials in inpatient facilities. That in a nutshell. For the rest of the situation in Belgium is relatively quite okay. We are in the slope a little bit like other countries, but we have a big buffer here of intensive care beds. So that's a little bit reassuring. So that's in a nutshell about the Belgian situation.
I think what we heard from different people across the world and the message that we are already receiving in the chat area, it's great that people across the world are really interested to help each other and see how they can basically be in solidarity with people in other countries that are now in the kind of really acute or really kind of hard time of this pandemic. So we will try to put together the resources that we have. There are some recent updates regarding the confidentiality and how you can break the confidentiality within the substance abuse treatment setting in US. I'm going to share those kind of recent updates on that. We are going to share that as well. So we put those things together. And just for the kind of last few steps, we are going to make a leadership core of those who are interested to invest their time in the next 3 weeks to see how we can basically organize whatever we have. During the last couple of days, different people in ISAM have been in touch for putting together this webinar. And I think I received something like 200 emails in just few days of kind of discussing with the different people across the world how we can do something together, specifically for this specific marginalized population. So those who are able to invest their time for a couple of hours to help us to organize whatever we already have and see how we can have a sort of a map about what is happening across the world, and also helping kind of put together different resources. Even within the ISAM neuroscience interest group, we have already started to put together something like a brochure about brain response to the stress when you are a substance user, and how kind of your brain would kind of face with difficulties in terms of the cognition when you are in the stress. So how your basically future time horizon would be disrupted, and you can be really susceptible to just looking for immediate rewards, which is going to be really harmful for your kind of your recovery, and how people can use those kind of information to be able to do something for themselves in terms of the recovery process. So we will try to put all those resources together. So those who are interested, please send us an email on the isam.nig@gmail. So we will try to organize kind of those people who are going to help in the context of the ISAM and COVID-19 response, and we will keep in touch. And the next webinar is going to be in something like 3 weeks. And we have already received kind of feedbacks from WHO, National Institute of Drug Abuse, and many other international organizations who are interested to contribute to the next webinar. And we already have discussions in this webinar about those things that people are doing right now. We definitely would be happy to see what will be the update in 3 weeks. Because as it has been discussed, it is not going to be a sprint. It's going to be a marathon. So we are going to be together for the next couple of weeks or even months to see how we might be able to deal with this evolving situation. And the last thing that we are going to put to kind of the recorded video of this meeting in one of the kind of our YouTube channels. So we will share that YouTube kind of link to you guys. And then if you have a specific comment or suggestion, please go down to that kind of YouTube video and put your comment to add to that video kind of channel, that then we can kind of negotiate and comment, something like a forum for discussion, how we can move forward from that point. Alex, the last words.
Last words. Yes, it's going to be a marathon, but we're all together. And I think, this webinar, considering the fact that it was organized in less than a week, has been quite successful. And it shows, the power of doing things, thinking things together. We're here to support each other. Hopefully we'll see you on the 15th of April, but in between, I'm receiving messages here that, if it is possible to share email addresses, if that's okay with you, we'll share that in order to continue this conversation. Unfortunately, COVID-19 is not going to go away. If it goes away, it will come back again. So our legacy is to learn from the responses and the solutions that we're finding out, and working away in order to, as I said, the moving target, in order to try and make sense of things. But hopefully the legacy will be that all this information will be available for everyone now and later on when COVID returns. So thank you very much.
Have a good day. Take care.
Thank you.
Thank you. Bye-bye.
Thank you. Bye.
Bye, everybody.